Welcome to the 38th session of the Transnational Vascular and Interventional Radiology Journal Club. We are an open access virtual initiative to educate trainees on clinical research studies pertinent to VIR through monthly journal club sessions. Each TNVIRJC session focuses on a randomized clinical trial or meta-analysis, so level 1 evidence, accompanied by an overview of the relevant disease and intervention. Today we're going to be having Michelle Dye and Desiree Duncan present on the STRIDE trial.
Hey guys, thanks for having us. My name is Michelle. I'm a year 4 student at Touro University in Nevada, and I'm joined by Desiree Duncan
Yes. Hello, everyone. My name is Desiree. I'm a fourth year student at Wayne State University School of Medicine in Detroit.
and Dr. V, who's from Kaiser Permanente Los Angeles. He will be our faculty mentor for this presentation. This presentation is on semaglutide and the walking capacity in people with symptomatic PAD, also known as peripheral arterial disease, and comorbid type 2 diabetes. This was a phase 3b double-blind, randomized, and placebo-controlled trial, and we'll be presenting the findings today. But before that, I would like to give you a little background on peripheral arterial disease. So worldwide, it affects 230 million people, 8.5 of which are adults in the United States. Epidemiology-wise, it's not going to get any better because our population is aging. There are several risk factors, one of the strongest of which is smoking. There are risk amplifiers, comorbid diseases that would increase your risk for developing severe cardiac events or needing an amputation, such as diabetes, chronic kidney disease, hypertension, cholesterol problems, obesity, and elderly age. It's often comorbid with other cardiovascular diseases, and the incidence happens the most in African Americans, then followed by Hispanics and non-Hispanic whites. Pathophysiologically, I wanted to discuss a little bit about the microvascular changes that occur in PAD, because this is critical to understanding how semaglutide works as well. So when you have an artery that starts to narrow, everything past the artery that it usually supplies becomes hypoxic, meaning that there's decreased oxygen, there's decreased nutrient supply, and all of this causes localized tissue damage to that area. How your body decides to respond to that damage is it goes through a cycle of inflammation. But through that inflammation, you get collateral damage to these vascular cells that result in thickened vascular walls, more risk of thrombus formation, platelet activation. There's more white blood cells that come to the area and form free radicals, which are damaging as well. This all leads to endothelial dysfunction, and it's really, really hard to reverse this. Over chronic amounts of time, this tissue remodels and it decreases the oxygen supply to muscles that it usually feeds. And that is when people start to get physical symptoms of muscle cramping and pain. So symptom-wise, people start developing intermittent claudication. What they feel is pain, cramps, and paresthesias, tingling. It gets worse when they exert themselves, and it gets better when they rest. It can happen at some common locations. One of them is aortoiliac, some are fem-pop, and some are infrapopliteal disease. But no matter where it forms, typically the distribution of where you will see the symptoms is distal to the site of claudication. So, for example, a fem-pop disease would have calf symptoms, and aortoiliac disease, which shows symptoms in the buttocks, the hips, and sometimes erectile dysfunction in males. Infrapopliteal disease would show foot symptoms. And as this disease progresses, people start experiencing pain even when they're resting, not even doing any sort of exercise or exertion. Usually this indicates a severe level of ischemia by that point, and it starts usually inside the distal locations where the blood supply is the worst. So typically the toes and the forefoot. It worsens when you lie down because this kind of redistributes the entire blood volume into your upper body and away from the lower body, which would make the claudication worse. And it improves when you use gravity positioning to bring blood back to your feet. Can also present even without pain, but you might get symptoms of weakness, numbness, and fatigue just as a consequence of poor arterial supply. Okay. Exam finding wise, you'll have non-healing, slow healing ulcers. This is an example of some of the gangrenous necrosis and ulcers that would take a long, long time to heal. You can see that on this leg as well. There's very little hair. And that's also a finding of peripheral arterial disease. Your nails don't grow well, they become brittle, the hair on the legs goes away, and then the skin temperature also feels cool. You sweat less. Muscles start to atrophy over a long period of time. Occasionally, some people will have the symptom of livedo reticularis, which is this blue net-like formation on their skin. Pulses will be hard to palpate, especially distal ones inside the foot, the ankle. And Berger sign is where you lift the extremity above the level of the heart, and that would kind of decrease the amount of blood that goes to that area. And so you'll notice that it becomes pale. And then when you replace it into a position of gravity, it will basically, all the blood will kind of flood back in, and you'll get something called reactive hyperemia, meaning the blood will perfuse the tissue again, and it will turn redder than usual. Sometimes you will hear a bruit, especially if it's not completely occluded. There are different subsets of PAD. The one that we're going to focus on in STRIDE is called CLTI, chronic limb-threatening ischemia. But in brief, there are asymptomatic ones. There's chronic symptomatic, which is you get intermittent symptoms, but when you take a break, your symptoms are quickly relieved. Chronic limb-threatening ischemia is you get pain at rest, you have lower extremity wounds that aren't healing and are gangrene for more than 2 weeks. There are different classification systems that we will go over for CLTI. And in brief, ALI, acute limb ischemia, is a sudden decrease in arterial perfusion that causes pain, pallor, pulselessness, poikilothermia, paresthesias, and paralysis. You might know this as the 6 Ps. This has threatened limb viability. It's a very serious issue and can lead to amputation. Something that we use objectively to measure PAD is the ankle brachial index. It's exactly what it sounds like. You take pressure at the brachial artery, you take a pressure of the dorsalis pedis, and you calculate the ratio between them. ABI less than 0.9 is diagnostic for PAD. 1.0 to 1.4 is normal. And if your ABI is greater, like 1.4, it might be from a calcified vessel. And so in this case, we would also want to measure a toe brachial index because the vessels inside the toe typically have less calcification than inside the dorsalis pedis. One other way we can measure this is also through walking distance. Inside the STRIDE trial specifically, they used a constant load treadmill, which has time and time again across many studies shown to be a reliable method of measuring how far someone can walk without stopping. It is better than the 6-minute walk test, which is also a very commonly used one. In this one, people walk for 6 minutes as far as they can, but they're allowed to take breaks and stop if they need to. So for the STRIDE trial, they use the Fontaine classification. This is actually rarely used these days clinically. It is based on the patient presentation and divided into 4 stages, with stage 2 divided by distance. So stage 2A is more than 200 meters, and stage 2B is they can walk less than 200 meters in the context of them having intermittent claudication. This was developed in 1954, so it's a little bit out of date. And instead, what we really use these days clinically is the Rutherford classification for CLTI. It also has like finer stratification, mild, moderate, severe, that allows for more precise risk assessment, prognostication, clinical decision making. And it also distinguishes between minor and major tissue loss, which is a very important factor in deciding what you want to do for your patients. And it comes with objective criteria as well. But for the STRIDE trial, they used Fontaine because it's very easy to define if someone can walk more than 200 meters. And so for this particular trial, it was better to use Fontaine. Typically, though, I want you guys to know that we use Rutherford and something called Wi-Fi in clinical management. So functional impairment versus disability was something that was also measured inside stride. Functional impairment means that you have limitations in your physical performance, such as you can't walk as far, you can't walk as fast, you need to take more breaks. And this is even if you don't have pain, you're considered functionally impaired if you can't walk as far. It can be difficult to detect functional impairment early in PAD because people typically experience a gradual activity reduction, masking the decline in their walking ability before you really catch on to this stuff. Disability is when the functional impairment starts to limit their ability to engage in usual social activities, such as getting groceries, doing their job, attending social events, and it decreases their quality of life. They can miss functional impairment in early stages of PAD, even if they're severely disabled. Early on in management for PAD, we do a structured supervised exercise therapy. However, this remains underused because of limitations in access. You know, it's hard to get patients transportation or organize meetings and appointments and coordinate all the people that need to play a part in making this happen. There's a lack of awareness of this existing and poor patient acceptance rates over long time periods. So there's also something called step monitored home-based programs. Basically, your goal is to create intentional claudication to encourage your body to create more angiogenesis and open up more collaterals to the area. It improves function, but they noticed that the patient's quality of life didn't actually change significantly. So sure, you might be able to walk more distance than 6 minutes, but it doesn't actually change your ability to go to groceries, do your job, things like that. And these were measured by questionnaires such as BAS-QLL6 and SF36, which we will go over. Also, early management, you want to aggressively control other cardiovascular and metabolic comorbidities, so diabetes, kidney disease, but also things like antithrombotics and hypertension meds and lipid-lowering therapies like high-intensity statins and things like that. These are examples of the questionnaires that they use. So BAS-QLL6, these are some of the examples of what symptoms they have, including things that they can't do socially and limitations. You can see that on the short form 36, there's different topics broadly that they try to hit inside the patient's life, and they create multiple questions for each subtopic. All right. So some of the awful things that could happen as a result of PAD are serious cardiovascular events such as death, stroke, MI, and major adverse limb events such as vascular amputation and repeat interventions, acute limb ischemia and chronic limb ischemia. Medication recommendations. In the past, we kind of explored using cilostazol and pentoxifylline. However, both of these drugs were found to improve walking distance without improving cardiovascular health, which is intimately tied with the pathophysiology of PAD. So there really is no reason why we should only try to treat PAD symptoms without also addressing the bigger overall pathophysiology of both disorders. So also cilostazol has terrible effects in congestive heart failure. A lot of people who have PAD and cardiovascular diseases also have some form of CHF. And so if you can't use a drug for most people, it's not a great solution for PAD. And pentoxifylline showed no meaningful effect on function whatsoever in some trials. So in Europe, these drugs are actually not recommended. These are recommendations pulled from the AAC. So late in management, you start getting into surgical options. We try to avoid doing these because it's usually a repeat intervention kind of deal. Endovascularly, these are just some examples of what we can do. You could use balloons, you could place stents, you can remove the plaque buildup on the wall. You can even use drug-coated balloons that contain drugs that prevent endothelial growth afterwards. There's also surgical options, including bypasses and endarterectomies. Also, amputation would be considered a late management surgical procedure. But basically, there is a gap in treatment. In early PAD, the Ironic trial showed that revascularization didn't actually show benefits versus control at 2 years. So if it's early, they don't really need revascularization. Try to avoid that. In late PAD, they need multiple recurrent revascularization procedures because even if you open up the area that was closed off, it doesn't undo all the microvascular or metabolic changes that happen distal to the area of blockage. And so we need something that addresses the broad pathophysiological factors that play into the PAD development, the inflammatory cycles, the hypoxic issues, the changes in metabolism, the effects on muscle metabolism, and control its progression before it even gets there. So enter GLP-1 agonists. You might have heard of this famous drug now, semaglutide. It feels like everyone's on semaglutide now because it's a fad. It has many, many effects. These are just like a picture of just about every effect that it has on the body. As you can see, it's got a lot of things going on. But what I wanted to point out in particular is the effects on the heart and adipose tissue. So on the heart and cardiovascular system in general, it decreases immune cell recruitment, increases angiogenesis, decreases thrombosis, controls atherosclerosis, and decreases endothelial permeability. And so all of these kind of also play in as a reminder into the pathophysiology of the microvascular changes that occur in PAD. And so the STRIDE trial seeks to understand how semaglutide can play into controlling PAD and improving PAD functionally. So in general, they have very broad effects, including improvements that were seen in weight loss, cardiometabolic effects, kidney, major adverse cardiovascular events, and heart failure. There were several trials done that showed improvement in heart failure with preserved ejection fraction using semaglutide. Current guidelines, however, do not prioritize GLPs over conventional therapies because there hasn't been evidence yet of a benefit of morbidity associated with PAD given semaglutide use. And also, one of the most common side effects of semaglutide is that it slows down gastric emptying. So patients will sometimes have like nausea, vomiting, and more seriously, sometimes pancreatitis and gallbladder problems. And so without further ado, that is the background for understanding STRIDE, and I'm going to turn over the conversation to Desiree.
Yes. Hello, everyone. First off, Michelle, thank you so much for all of that background and the introduction as well. I think that everything you talked about will help us better understand the need for the STRIDE trial and kind of better understand the implications of the findings of this study. Next slide, please. Okay, so a lot of these things Michelle kind of already talked about, but just to briefly kind of reiterate to kind of better understand the rationale behind even doing this trial in the first place. So with regards to PAD, it affects many people. One of the main effects is functional decline. So the walking limitations, claudication is among some of the most disabling aspects of peripheral arterial disease. There's also an unmet need that exists, which is another reason why this trial was super important. Because kind of like Michelle was talking about earlier, there are very few therapies that exist. We have cilostazol and supervised exercise therapy, but there are limitations with regard to these therapies, which is why this trial to kind of investigate a novel therapy for PAD was really needed. And so the rationale behind even doing this study is that so GLP-1 receptor agonists, they have many vascular, metabolic, and anti-inflammatory benefits. But we wanted to know if they could also improve function in patients with peripheral arterial disease. Next slide. Okay, so the whole objective and aim of this study was to test whether semaglutide improves walking capacity, symptoms, and quality of life in patients with PAD and type 2 diabetes mellitus. Next slide, please. Okay, so how was this study conducted? So this was a phase 3B double-blinded randomized placebo-controlled trial. And just I put a visual kind of the different phases of clinical trials just as a brief background to kind of better understand at what point this study was conducted. The population analyzed in this study was patients with type 2 diabetes and symptomatic PAD. The study included 792 patients, 18 years or older, that were classified as Fontaine stage 2A, and they were defined as having PAD by utilizing an ABI or a TBI. The intervention used in this study was either semaglutide, 1 milligram weekly, versus placebo for 52 weeks. And like I kind of mentioned earlier, this study was double blinded, so neither the researchers nor participants knew whether they were receiving semaglutide or placebo. The sites that were utilized in the study, there were 112 centers that partook in the study across 20 countries in Asia, North America, and Europe. And one of the primary endpoints for this study was change in maximum walking distance at 52 weeks on a constant load treadmill. And the significance of using this primary endpoint is that patients essentially served as their own control. So at the beginning of the study, it was seen how much they could walk maximally without having to stop. And at the end of the study, this was taken again to better understand the benefits and the changes that occurred in terms of walking distance in these patients. And what was used to kind of quantify this change, something called median ratio to baseline. And just some key secondary endpoints that were also looked at was walking distance at 57 weeks. So post-drugs, they looked at the walking distance that patients could undergo after finishing treatment. So they were trying to get a better idea of whether or not semaglutide had any long-term benefits even after treatment had ended. They also looked at pain-free walking distance, and then they also looked at a PAD-specific quality of life questionnaire that Michelle showed us earlier called the VAQ-QOL-6. And the whole purpose of using a questionnaire as well was because they wanted to see if this treatment with semaglutide also kind of improved the quality of life subjectively, like from these patients. So this was kind of like a subjective measure used to see if there were any benefits in terms of quality of life. Next slide. Okay, so in terms of participants in this study, there were 792 that were randomized. So it was 396 patients in each arm. There was a median age of 68 years, a lot more males in the study than females. And like Michelle talked about, each patient had Fontaine stage 2A, and baseline functional status across all patients was also analyzed as well. So the maximum walking distance at baseline was about 185 meters. Pain-free walking distance was about 110 to 120 meters, and 65% of patients of the participants in the study reported moderate to severe walking limitations, and 62% reported moderate to severe quality of life impact. So so the main purpose of them looking at walking limitations and quality of life was that this large number of participants are experiencing obvious morbidity from their disease, which we kind of see by these kind of large numbers of participants reporting walking limitations and reporting that their PAD is in fact impacting their quality of life. Okay, next slide. Okay, yeah, so this study was done on an intention to treat analysis study design. So if we kind of look at this table right here, we see that there was over 1,000 patients that were screened. There were some that were excluded. Then the 792 were randomly assigned. And if we go kind of further down this trend, we see that some did not complete treatment for a multitude of reasons. And it kind of breaks down how many patients in each limb completed treatment and how many overall completed the trial. So the main reason for using an intention to treat analysis is because it kind of helps to better eliminate bias on the statistics end. because patients that were assigned to a treatment group were analyzed at the end as assigned to that group, whether or not they completed the treatment. So yeah, I just wanted to kind of highlight that and highlight this study design and why this design is important to kind of mitigate some of the bias that can happen in studies when looking at variables like these. Next slide, please. Okay, so results. So one of the primary endpoints utilized was maximum walking distance at 52 weeks. So in our treatment group, our semaglutide group, there was a median ratio to baseline of 1.21. And basically what this means is that there was a 21% improvement in these patients' maximum walking distance as compared to baseline. And we see in our placebo group, there was only what comes out to be an 8% improvement in these patients' maximum walking distance. And another value I really want to highlight that I think kind of speaks volume in this study is the estimated treatment ratio. And this was 1.13. And what this value represents, because it's 0.13 greater than 1, what it's telling us is that patients in the treatment group had a 13% improvement in maximum walking distance at the end of the trial as compared to placebo. So by taking this ratio, you're kind of looking at the experimental and control group and seeing the overall ratio of improvement. So that 13% number that we kind of see, which all ended up proving to be statistically significant. And I also just wanted to conclude some absolute gains as well. So in terms of median improvement, patients in the semaglutide group were able to walk about 26.4 meters more than placebo, and mean improvement was about 39.9 meters versus placebo. So what we're seeing here is that patients are able to walk a lot further along in our treatment group, which is kind of to be expected because, like Michelle kind of talked about earlier, some of those anti-inflammatory benefits are kind of hypothesized to contribute to why patients that are taking this medication are able to have better exercising capacity. So by decreasing some of those factors that contribute to disease severity in PAD, what we're seeing is an improvement in these patients' ability to walk and not experience less or mild claudication. So that way they were able to walk for further distances. And just some other key points that I thought were kind of super relevant as well was that there was significant improvement in the amount of pain-free walking distance in patients in the treatment group as compared to placebo. And in terms of these questionnaires that Michelle kind of brought up earlier, patients in the treatment group showed significant improvements in terms of the way that they reported their quality of life with regards to PAD, as well as just reported overall improvement in quality of life. So our VASCU QOL, kind of QOL6, represents quality of life with regards to PAD, and patients in the treatment group showed to have improved quality of life with regards to their PAD symptoms and morbidity. And in terms of overall quality of life, patients in the treatment group also still showed significant benefit in that regard. So this is super important because quality of life for these patients, we saw from the earlier slides that I presented that it was a significant kind of, it was shown to provide significant morbidity, and patients were very affected by their PAD. So to see that not only are patients able to walk for the distances, but they're also reporting improved quality of life with regards to their symptoms is super important and kind of nice to see that it kind of translates clinically as well. Next slide. Okay, yeah, and just to kind of talk about some secondary endpoints that I thought were super important as well. So kind of looking at the long-term benefits of semaglutide, even after patients completed the therapy and the drug. So one of the secondary endpoints, like I kind of spoke of, was findings at week 57. So the study drug was utilized for 52 weeks. So from 0 to 52, patients were receiving weekly doses of either placebo or the semaglutide. And at that 52-week benchmark, they stopped receiving the drug, but they still measured the effects on walking distance after patients stopped receiving the semaglutide or the placebo. And what they saw was that in terms of median maximum walking distance ratio to baseline, in the treatment group, we see that that patients still had a 16% improvement in their maximum walking distance compared to baseline in the treatment group, whereas in the placebo group, it was only a 10% improvement with regards to their maximum walking distance. So what we're seeing here is that even after therapy had finished at 52 weeks, there's still a kind of long-term benefit that we see in these patients. So yeah, and another point I just wanted to bring up was that in terms of rescue therapy and all-cause death composite, the hazard ratio for these two values was 0.46. And basically what that is telling us is that a hazard ratio of less than 1 is showing that patients in the semaglutide group and our treatment group were significantly less likely, almost half as likely to require rescue therapy or experience all-cause death as compared to the placebo. So yeah, next slide, please. And yeah, this is just a table from the results section of the study, kind of just specifying kind of just showing graphically the information that I provided in the previous slide. So if we look here in the A portion, we have our semaglutide group represented by this red line, and we have our placebo group represented by this blue line. And in terms of kind of parameters that were used and kind of like used to get these results. So we see that our observed median ratio to baseline in terms of maximum walking distance is significantly higher at 52 weeks in our semaglutide group. So with that being 1.21, whereas the median maximum walking distance of patients ratio to baseline in the placebo group was only 1.08. So what that kind of equates to is that in our treatment group, patients had a 21% improvement in their maximum walking distance as compared to the only 8% improvement seen in the placebo. And yeah, and then these other values just kind of reiterate the things that I was saying in the previous slide, kind of with regards to looking at pain-free walking distance at 52 weeks, as well as the maximum walking distance at 57 weeks. So yeah, we can go to the next slide. Okay, so last, I just wanted to talk about interpretation of these results, as well as kind of introduce a discussion as well. So overall, we saw that semaglutide improved walking distance by about 13% versus placebo, which is clinically meaningful, especially when comparing it to the current standard treatments. And as well as another thing that we saw was that the effects of this medication were durable. So they were evident halfway at the 26-week mark, they were evident at 52 weeks, and they persisted after discontinuation at that 57-week mark. So, and the mechanism of which this was able to happen. So patients in the study did experience modest weight loss from the semaglutide, but it's believed that this is not significant with regards to this study because the benefit was likely, so the reason that we were able to see increasing walking distance was likely due to the vascular and anti-inflammatory effects of the drug, as opposed to the weight loss component of it, because there was not that much weight loss in these patients. And they also calculated the ankle brachial index and saw improvement in that value, which kind of further proved that this effect that we have seen was not due to weight loss from semaglutide, but rather likely a benefit of the vascular anti-inflammatory components of the drug. And another thing that we saw in this study was that there was improved quality of life based on the 2 questionnaires that were used, and there was a reduced need for rescue therapy. So what this kind of equates to is real world impact. So patients with PAD are reporting better quality of life as with regards to the morbidity of their disease and we know this because of the questionnaires that were used. So yeah, next slide. Okay, and just some kind of key takeaways. So what semaglutide represents is a novel therapy for PAD with kind of 2 benefits. So not only does it provide a cardiovascular and metabolic protection for these patients, but we're also seeing that in improving walking function and quality of life with regards to some of the morbidity associated with PAD. And another big thing about this and why it's so important because it has the potential to kind of reshape the treatment paradigm beyond what's currently used, such as cilostazol and exercise therapy. Because while those 2 treatments do show to kind of improve walking distance in patients, these treatments don't have the added benefit of cardiovascular and metabolic protection for patients, which could be a reason why semaglutide will be used over these current therapies and kind of change the way that we're practicing medicine. So yeah, and overall, this is supporting prioritizing GLP-1s in patients that have PAD with diabetes. It's a large randomized controlled clinical trial showing that this GLP-1 agonist improves walking capacity in these patients. And yeah, overall, semaglutide, based on the study, was shown to significantly improve maximum walking distance, pain-free walking distance, as well as overall quality of life in patients with PAD and diabetes. And what we see here are clinically meaningful, durable, and consistent across all subgroups. So basically, a big takeaway from this study is that it's important to consider using semaglutide as opposed to other treatments for PAD because we're seeing a lot of the long-term benefits of this for patients with PAD that not only kind of improve the quality of life, improves those symptoms of claudication and things like that, but also add that additional cardiovascular and metabolic protection as well. So yeah, that's all I had. And these are just some references from like the pictures I had and things like that. And reference from the study. Yeah, that's it.
Thanks.
Very difficult topic, very broad, but yeah, it's very important to know that 8 to 12 million Americans have peripheral arterial disease, and again, they can have it isolated or they can have it concomitant with coronary and cerebrovascular disease. So the polyvascular disease is cerebrovascular, coronary, and peripheral vascular, but those are a pretty thick subset. So should just be familiar and aware of that triage. Okay. Now, when you're looking at PAD, there's a symptomatic PAD, which has a diminished ABI between less than 0.9, and then greater than 1.3 is what a lot of people utilize. And then after that, like you said, it's going to be calcific vessels that are diseased. So that's important kind of construct. Some people use toe brachial index, these other things of that nature. Now, once you go to asymptomatic in the U.S. Or the Rutherford criteria is mild, moderate, severe claudication, but that's kind of subjective. What is moderate versus severe? So severe is often what we call lifestyle limiting or disabling claudication. So meaning you can't work or you can't do your day-to-day activities. So again, that's still a little bit subjective. If someone really loves golf and they can't golf, is that disabling claudication? Perhaps. The Fontaine classification enables you to break it down 200 meters greater, which is kind of, it's kind of an interesting way to kind of break it down, and that's the kind of European kind of to utilize. But most of the articles will use Rutherford, especially when you get into the Rutherford 4, 5, 6, which is rest pain, minor tissue loss, and major tissue loss, which is kind of proximal to the kind of the midfoot. So then you kind of break it down to if you're claudicant. Really, you have if you look at the broad base of claudicants, and it's important to stratify, Is this clot, as you get older, right? If you look at the partner trial, it's a very important trial that Alan Hirsch published looking at family practice population, and they took a general kind of survey and looked at patients who were, between 15, 70 diabetes and smoking or age over 70. There was a high preponderance of PAD that the primary care physician was unaware of oftentimes, and that was up to 29%. So pretty high prevalence in this aging population that we should all be familiar with. Now, when it comes to claudication, it's very difficult to discern. In fact, the majority of patients are not going to have what's called the classic Rose or Edinburgh classification. And that's where you know what that is, guys? Like classic claudication.
Yeah, so cramping, lower extremity pain that is onset with exertion, relieved by rest, and reproducible.
Yeah, exactly. So the classic one is usually calf or buttock or thigh, depending on location. It appears at a certain amount of time, a certain distance, certain amount of activity, and then when you stop, it gets better. The reality is, majority of patients will have what's called atypical leg pain, and that's because they're going to have a slew of other musculoskeletal neurologic ailments that are going to impact them, whether it be spinal stenosis, sciatica, venous disease, knee pain, hip pain, ankle pain, back pain, that are going to really be part of the problem. Now, this study did try to exclude those with heart failure or musculoskeletal issues as the rate limiting factor. The one benefit of a kind of a treadmill test or things of that nature, when you're testing them, you can figure out what causes them to stop. Is it chest pain? Is it shortness of breath? Is it knee pain? Is it hip pain? What is the cause? And again, hip pain can be actually claudication symptoms. So be careful with the aortic disease. You can have hip pain. So the number one thing is when you see patients in the clinic, you will have a hard time discerning what the cause is. So it takes a lot of practice to figure, is this spinal stenosis? Is standing for a period of time, does that cause it? Stooping over, does it make it better or worse? All things are really impactful and important to understand. Okay. Next, claudicant or atypical leg pain, the natural history is relatively benign when it comes to leg amputations. What's the risk of a limb loss or amputation in that population, roughly?
2 to 3.
Yeah, it's very low, less than 5% in 5 years. So the natural history of a claudicant is fundamentally different than a critical limb ischemia patient who has a wound and not healing wound. So that's very important to understand that. What's the risk of limb loss if you don't fix a patient with a wound in CLI, poor circulation?
Like 25%.
Yeah, exactly. 25% are going to lose their leg in 6 months a year. Now, claudicant has a very high risk of a heart attack and stroke. So as important it is to improve their walking, more important is to prevent a heart attack and stroke. And how do we do that? Statins. So your goal LDL is less than 70, arguably less than 55. Lower is probably better based on many of the trials, including the PCSK9 is like 4 years, pretty low, right? Ezetimibe. These other agents are adjunctive to high intensity statins. Lower is probably better. What else?
Antithrombotics.
Yeah, so you could argue antithrombotics based on someone had mentioned Compass, right? Compass maybe in a polyvascular patient with a low bleeding risk, maybe a reasonable adjunct to use an actual true antithrombotic, such as a low dose DOAC. What else?
Or antithrombotics, also including like aspirin or Plavix.
So yeah, you could argue maybe Plavix, right? Based on a pre-trial, where you see some potential benefit in the subset of ischemic events in the PAD population when compared to aspirin. There's a bit of controversy in aspirin, but regardless, maybe that, right? So antiplatelets, anticoagulants, can you close the door? And then also, what about any role of any antihypertensives?
Yeah, so blood pressure control.
Yeah, exactly. So blood pressure control, right? So goal less than 130/80 usually in the diabetic population, the reasonable adjunct. And independent of blood pressure control, based on the HOPE trial, or the Heart Outcome Prevention Event Act trial, which used ramipril, there is a benefit ACE inhibitors, right, in reduction of these cardiovascular events. So you need to understand the statins, ACE inhibitors, antiplatelets, and antithrombotics have some beneficial role in preventing heart attacks and strokes and cardiovascular related mortality and morbidity. Very important, right? So these patients should be on these meds with these goals. Now you want to improve their functionality, right? So how do you improve the functionality? Well, the number one thing you can do, which improves walking distance the absolute most, is Clever trial. Yeah, Clever
Supervised
trial, which is
exercise
supervised exercise, or I send a link on the Goals trial, right? Which is Mary McDermott and Gardner. They've done a lot of trials looking at not supervised exercise, which can be costly, but home-based therapies, right? And so being a coach and bringing them back is very important. And if you look at this trial, what I think may, I don't know, is they brought him back at 1 month, 2 months, 3 months, 6 months, right? And then at 1 year, they brought him at 49, 52, and 57 weeks. Did that have the impact on having them kind of do that? Though they were not a true exercise regimen, that's something to think about. All right. So I do bring them back at 1 month and 2 months and 3 months and see how, and I have them carry an exercise log. I tell them to walk till it hurts 7 out of 10, stop till 3 out of 10. And I walk them in the office to guide them. And I have them log distances and pain. Okay. So I think it's important for you to do that in the office. So exercise clearly works. And they have level 1 evidence, multiple trials that show that. 2, Salosasol, right? I mean, in this article, it doesn't say it, but up to 50% improvement in walking distance at 6 months. Most of the trials take 6 months. Here, if you saw at 6 months, the increase was what, 10% over their baseline? So I thought that was kind of interesting. When you look at kind of claudication improvement in time frames. And then those are kind of the main things, right? Exercise this, and now semaglutide is a new agent, and then statins. So Emil Moeller published data looking at atorvastatin 20 versus 80, showed an improvement in walking distance as well at 6 months. So statins also have an improvement in walking distance based on Emil Moeller's trial. So now we have a few things. Statins not only improve function, but clearly reduce event rates in patients with vascular disorders. All very important things, okay? So statins, ACE inhibitors, antiplatelets, and then functionality, exercise, statins, and salosol are benefit. And now we have a new agent that we can also add as an adjunct, and that's semaglutide. And I think that's important also to be familiar with and aware of, okay? So this new trial is just adds another thing to repertoire in a patient who's diabetic, right? Let's see here, what else? So now we have, when we look at the trial, I think it is interesting because it's a double-blind, randomized control trial, so the highest level of evidence you could do, right? For adjudicated peer lab review, they did injection with a semaglutide, and they did injection with on a weekly basis with a placebo, and they had a Fontaine classification, and they did a treadmill at 12% grade, 2 miles per hour. All right, a fixed speed, so you knew how far they were doing. It's pretty reproducible, and they had a good number of randomized patients, and they had a breadth of North America, Europe, and Asia, and a significant 25% female. So at least you can look at the genders kind of as well, and the average age plus 70 years, right? So it's all good data in that regard, right? Mostly Caucasian is what 70% a white population, so that's also important. So 30% were non-white. So it gives you some idea of kind of the diversity of the population, which is helpful when we're discussing with different patients, right? Will it work for you or not? Okay. Again, they did, when you look at the primary endpoint and what they achieved, when you look at the percentage, as Desiree mentioned, it was like a 10 to 20% increase over a year, right? But the placebo improved, right? The placebo improved from baseline 8%, 6% at 6 months, and 8% at 1 year. Why is that? Is it because they were bringing them back at 1 month, 2 months, 3 months, 6 months, and then yearly? Is that why? Even though there's no prescribed exercise regimen, is it because on any trial the Hawthorne effect occurs, where patients are under a trial, so they're going to perform better, they're going to eat the Mediterranean diet, they're going to make sure they're taking their pills, they're going to walk more, and they're being looked at closely, so they have a coach. Is that why? So these are all things you have to think about as to why, right? And I think that's another important thing. So from the trial standpoint. I think PADs are very important. Is this another adjunct? Potentially, right? You have a patient with CKD and diabetes. You have a patient with diabetes. You have a patient with maybe heart failure, preserved EF. You have a patient with PAD now and diabetes. You could argue that may be benefit. The one thing that I thought was interesting, though, the extent the weight loss was substantial, it was not trivial. I think it was like almost 9 pounds in the semaglutide population versus I think, a couple pounds in the non-semaglutide population. So that's not trivial. Or maybe more, sorry, almost like 11 pounds in the semaglutide versus about 2.5 pounds or 3 pounds in the placebo population. So again, it's not an insignificant difference in my opinion. If you lost 8, 10 pounds, your BMI is in the average is like 28. That's a lot, right? Versus 2, 3 pounds. Psychologically, physically, who knows, right? So just things that we should think about, even though the p-value is not significant, it's still something to think about, right? A1C's dropped, about 0.8% in the semaglutide versus 0.2%. So again, if you're going from a 7 to 6.2 versus a 7 to 6.8, that's not trivial in some ways. So these are all things when you're talking to a patient, you need to be able to counsel them on. Hopefully that makes sense. So then when I'm looking at it, I'm like, okay, what do I tell a patient? This is an injection that patients may not like, right? It's costly, it's $1,000 every month, etc. Whereas exercise, supervised exercise not cheap, but you being a coach in exercise is relatively cheap, right? And if you bring them back monthly, yeah, it's more physician time, but still, maybe that's the way to go. And you can potentially get all these downstream benefits. The impressive thing is the placebo limb did pretty well. I was surprised that they got better. So I do think there's valuable information from this, and I do think it's something we should certainly consider, especially if they have other reasons. Right? To add, this is another reason to add it on semaglutide, right? Weight loss, CKD, etc., A1C management, so on and so forth. It may be something to consider. Great. Any other thoughts? Anybody else?
I had one question. For the inclusion criteria for this study, I think they included people that were Fontaine 2A, I believe.
Yeah.
But I think so. I know we were saying that the one of the bigger issues with PAD is that we're missing the very early claudicants, and that's a major population that we're missing in treatment. And given that this is a lot of like these claudicants is a more chronic process that has to do with inflammation, given the pathophysiology of that, are we losing, for example, class 2 patients who have intermittent claudication who might also benefit from semaglutide, which targets the early pathophysiology? And like, is this inclusion criteria kind of hampering the generalizability of the study? And so I just kind of wonder about the inclusion criteria here.
Well, I mean, I think the question is, should we even be screening ABI? Should that be done?
Right.
And the argument is we've submitted that, but when you're looking at healthcare population screening, it wasn't deemed to be valuable enough to pay for or reimburse. So the answer is, if you identify a peripheral vascular disease in your office, I would treat them aggressively with statins, ACE inhibitors, and potentially antiplatelets. And that way you reduce your cardiovascular events. And I think you walk them, right? You counsel them on smoking cessation, and you put them on varenicline. You put them on nicotine replacement therapy. I think that's what we do. I think we keep our diabetics under a goal A1C less than 7% to prevent nephropathy, neuropathy, and retinopathy, which will have such global impact. And if you put them on a Mediterranean DASH diet, you're going to drop their blood pressure, you're going to drop their weight, you're going to reduce inflammation. So those things I think are so tremendously impactful that's what we should be counseling patients on, right? And we educate every diabetic you see in the office. Educate them about take off their shoes and socks, look at their feet, look at the heel, educate them about dry skin between the toes, proper orthotics, cutting flat, make sure you do proper toenail care, right? And using a selfie stick. Those are the key things that you can really reduce events, right? Is smoke cessation, those things. Like, yeah, we can add these expensive drugs early, but is that really what's going to benefit the millions of patients that could, by you telling them do these things? That they'll impact a lot more, right? So even the semaglutide, you could argue metabolic-associated liver disease can be impacted. Well, so can 10% weight loss. I saw a patient today right in the clinic who came in for some other process, but we counseled her on 10% weight loss, which is really her goal and drive. I think she came for hyperaldosteronism workout, and she's like, I really want to try this plan for And I'm like, I agree with you, because the impact factor on your overall body would be much better including weight loss, blood pressure reduction, diabetes control, than this intervention that I do. So I think we have to think about holistically, how can we prevent all these metabolic associated problems and chronic conditions that we're dealing with, which are related to diabetes and hypertension, obesity, diet and exercise, simple as 10,000 steps. And if we can educate every patient about that earlier on, we'll have such a tremendous reduction in event rates.
Right. That makes a lot of sense. I think also with drugs like Ozempic, this is just like a very classic tale in medicine that treatments that are invasive, like an injection, or very expensive, also don't have good like adherence or compliance over time. Whereas habits like what you're talking about early on with walking and things like that, that might have a higher compliance.
Yeah, long term, that may be the better way to go for patients, right? And I think that's where we have to kind of start educating the earlier the better. The pediatrician should do it, the family practice should do it. And quite frankly, every specialist who sees a patient, right? That's your responsibility. If you're a vascular specialist, which many of you are going to go into VIR, this is your responsibility. Every diabetic take off their shoes and educate them, right? And it's just a family. It's not just the individual, it's the family, right? You have to educate the whole family about it. What are your thoughts also?
Yeah, I mean, just to chime in on that. So, I mean, there's a few ways you can practice VIR. And some people, maybe some of your attendings or people you rotate with will tell you that, it's quote unquote not our job, or it's someone else's job to do all of it. And especially in terms of like, lifestyle management, or pharmaceutical management, non-operative management. But the truth is, at the end of the day, the healthcare system is overwhelmed. Primary care physicians have, 2 patients booked in 15-minute slots. With not everyone's following up with their primary care. They may be only following up with you because you're the one operating on them. They may not even see their primary care. So, and medicine is getting so subspecialized. And one of the benefits of being a VIR is you're able to approach a lot of different organ systems. So it's really, you have to think about what kind of doctor do I want to be? What kind of doctor would I want my parent or friend or whoever I care about to be treated by? And I think, VIR is an amazing specialty where you can have a lot of benefit on people from a lot of different angles. But to do that, it takes a lot of training and clinic, and
A lot of clinics.
it's a lot harder.
Well, no, it's better, right? So we counsel 2 patients based on their FIB-4 score, right? One we're going to send for FibroScan, the other we're like, hey, your FIB-4 is still low, but you definitely have fatty liver. And if you lose 10%, you have a dramatic impact, right? More so than anything I do. So those simple things are probably more important than most of what I do. So these are things you guys should be learning and using in your day-to-day practice. Every diabetic you see, for whatever it may be, for on the floor, biopsy, doesn't matter, drain, just educate them. All right, good. Any last thoughts, anybody?
Just
Thank you,
curious about,
everybody. Oh,
yeah,
sorry.
yeah, just curious about how this changes your management. I know, like, if you look at HA 2024 guidelines, there's, class 1 recommendations for, SGLT2, as well as GLP-1. So kind of already starting people with PAD on these medications. Does this maybe change, taking someone that's on a different medication for the diabetes to these medications, because you can cite, walking distance, anti-inflammatory effects?
Yeah, I think when you're looking at kind of heart failure or CKD or diabetic control, and you have this as well, I would consider it that, yes. So now I'm getting multi-benefit, right? I think in that population, I think it makes a lot of sense personally. But if I was just looking, I said PAD, and then diabetes, maybe not. But if they have other adjuncts, things that I could potentially benefit with semaglutide, because it's really a kidney and heart drug almost, right? As opposed to a diabetic drug. So in those populations, I would consider it, right? And like you said, in heart failure, guideline-directed therapy includes, SGLT2 inhibitors now routinely, right? That's part of the guideline-directed therapy, and it improves survival and reduces hospitalization for heart failure. So I think, yes, you take it as a spectrum, and this just adds one thing. It doesn't seem to hurt compared to placebo, really, and it has some benefit. Now, there's a cost to it, but now if you add different organ systems that can be benefited, then I do think it makes sense. So I will consider it for that patient population that has various kind of organ-based issues. Yeah. Any other questions?
I'm sorry, I had a question. Thank you so much for explaining some of these concepts. And I wanted to bring it back to something that you had said because lifestyle changes really make such a huge difference. And I think some parts of this trial also said that the anti-inflammatory effects of the semaglutide was to be responsible for the benefit that the patient received. Do you see other diabetic medications such as metformin that also claim to have anti-inflammatory effects also having this similar results in patients, or is there something about semaglutide specifically that is more targeted to the anti-inflammatory effects? And also, can you replicate this, like you said, with lifestyle changes? Like, would you consider other medications for anti-inflammatory effects, or would you like also recommend other lifestyle changes that may be reducing the inflammation in the body that could help with claudication? What are your thoughts?
Well, no, that's a very good question. So statins and ACE inhibitors, beyond their kind of blood pressure reduction and their LDL reduction, have pleiotropic effects and anti-inflammatory effects and plaque stabilization and other and remodeling of the heart and other organs. So you're right, right? If you look at ramopril in the PAD subset of the HOPE, there wasn't a substantial drop in blood pressure. So it's a class effect maybe of that ACE inhibitor that's independent of the blood pressure reduction. So there probably is a lot of very complex kind of biochemical impact on these various drugs that are anti-inflammatory that are beyond just the kind of mechanism of action of class effect. So that's kind of way like, and it could include metformin as well, right, from a potential weight reduction and other adjunctive benefits. Yeah, good question. Any other questions?
Dr. V, so do you think that the next study following this would be defining when to start adding semaglutide?
Yeah, I mean the question is like again, if you were just doing it for walking distance, right? I would want to compare it to something else that is proven, whether it be exercise regimen or cilostazol, maybe even. I would, just for that, I'd be curious to see if it's just for improving walking, and that's when I'm counseling patients. Oh, I'll take this for walking. I'd love to go head to head and see what happens.
I also wonder if reducing intake of inflammatory foods could also improve walking distance, because I think a lot of Eastern medicine gets into inflammation in the body and how diet plays a role in that. So I wonder if there's a crossover there.
I mean, probably, right? I think the DASH diet, Mediterranean diet, reduce, kind of blood pressure and other kind of benefits. If you look at the Ornish diet, it reduces LDL, it reduces events, and reduces cancer. So probably, right? So I think it's harder to do in the current environment when kind of the cheap processed and packaged foods are readily available, and they kind of the greens and the kind of that component is super expensive and harder to get to. So these are things that we have as physicians and health, people in healthcare will have to push, government and others to kind of, hey, this is what needs to happen, because we can spend a lot of money in pharmaceuticals, we do a lot of device stuff, but if we don't fix that component of walking more, and kind of minimizing the sedentary lifestyle and increasing and changing the kind of what we eat and changing our populations what we eat, are we going to have a great impact? Maybe not, right? Because if you look at the average age lifespan in the U.S. is for the first time in decades coming down. So we need to fix that somehow. So how can we spend more and more money on our population and have worse results? So it's much more than just the drugs. Anyway, these are things you have to think about. This is like your futures to figure these out. And as an intravascular interventionalist who deals with a lot of disease, whether it be stroke, peripheral arterial disease, renal vascular disease, right? Hypertension, whether it be secondary cause of hypertension, right? And you're going to see a lot of diabetics. You're going to see a lot of MASH cirrhosis or MASH MAFLD. This is going to be what you guys have to work on: metabolic disorders, chronic knee pain, chronic back pain, hip pain. These are all disorders you're going to be dealing with that can be mitigated by kind of fixing some of these problems. All right.
Thank you so much, Dr. V. These were some great pearls. Thank you for your time, and then also thank you to Michelle and Desiree for putting together such a thorough presentation. Um, we're going to be uploading this presentation to YouTube, and if anyone here is interested in any of our past or future sessions, please check out our website. I'll drop the link to the website in the chat right now.